Good evening. My name is Dr. Kamal Kumar. I am medical lead from Ajanta Pharma Limited. And on behalf of Ajanta Pharma, I welcome all of the esteemed experts and the delegates for today's digital dialogue on advances in precision management of hyperuricemia and gout impact for India. Before going to presentation, we would like to show you a small clip as gratitude to all of the doctors who are serving relentlessly in this difficult time. Pratik, kindly show the clip, please.
Namaskaram. My deepest appreciation to all the doctors and pharmacists of the Ajanta Pharmacy, because at times like this, your service and your sacrifice is of utmost importance to this nation to come out of these difficult times. In these challenging times, every one of you have stood up and shown the way. Nation is in deep appreciation of all that you're doing. As a part of saving the saviors, we are offering various tools so that in these challenging times you can go through this much more easily. So many tools to bring stress levels down, to bring peace and calm within yourself, and also the inner engineering online program is being offered free of cost for all the medical personnel. Please make use of this. I wish to express our gratitude and my blessings are always with you. May you continue to serve the people and the nation. This is very, very important, your profession. The value of being a doctor, the value of being a medical professional is being understood by everybody right now. Those who serve without being concerned about their own well-being become worship-worthy. My blessings are with you.
Thank you, Pratik. Yeah, so once again, a very warm welcome to uh, all of the experts and the delegates for today's digital dialogue on advances in precision management of hyperuricemia and gout impact for India. So we have a good fortune to have Dr. Robert Terkeltaub with us as international speaker. We have Dr. J.K. Sharma as moderator for today's meeting. And among panelists, we have our esteemed experts, Professor Lieutenant General Chaturvedi, Dr. Sapan Pandya, and Dr. Indrajit Sardar as our esteemed panelists for today's meeting. So first of all, on behalf of Ajanta Pharma, I would like to salute all of the doctors who are the true warriors in the current pandemic battle. We thank you all doctors from our bottom of our hearts, sir. And as a appreciation towards our contribution of rupees 30,000 square feet COVID center with ICU facilities, Ajanta was appreciated by Governor of Maharashtra. We had committed rupees 6 crore to fight COVID-19 towards this pandemic. And Ajanta Pharma Limited is committed to serve healthcare needs worldwide. Since 1973, we are present in India. We have more than 150 first-to-market products in India in last 10 years. And we are spread across 30 countries with 6,500 Ajantites dedicated team from 28 different nationalities. We have 8 state-of-art manufacturing facilities in India and Mauritius, and we have 2 US FDA units in India, in Pathan and Aurangabad and Dahej in Gujarat. So we have very strong R&D thrust with more than 750 scientists dedicated with state-of-art facilities in R&D, and we have very strong presence in select segments like cardiology and diabetology. We have our presence in ophthalmology, dermatology, and pain management. With this, I would request Dr. Sharma to kindly introduce our international speaker, Dr. Robert Terkeltaub. Dr. Sharma, over to you, sir, please.
Thank you, Dr. Kamal. Good evening to all. I will take the privilege to introduce our today's speaker and the guest, Dr. Robert. Dr. Robert Terkeltaub is a McGill University medical graduate, and he completed his medical residency and rheumatology fellowships. After immunopathology postdoctoral research training at the Scripps Research Institute, he joined University of California, San Diego faculty in 1985 and served as professor of medicine. So, Dr. Robert has extensive research achievements in gout and translational inflammation, skeletal and arterial biology, clinical trials, management guidelines, and outcomes. And he has published pioneering work in gout and in innate immunity modulated and metabolically regulated chondrocyte pro-catabolic and pro-calcifying differentiation therapy targets for diseases of the pathologic calcification and tissue degeneration. He serves on multiple editorial boards and NIH and Foundation Scientific Advisory Committee. And today we are going to listen to Dr. Robert on this very important topic related to the uric acid. So
Uh,
I
yeah, thank you, sir. Thanks a lot, sir. And now I would take this opportunity to introduce our esteemed experts to the delegates. Dr. Jugal Kishore Sharma is Medical Director at Central Delhi Diabetes Center, New Delhi. Dr. Sharma is visiting professor and faculty of Department of Medicine and Diabetology at JN Medical College. Uh, and he's vice president of ACP, American College of Physicians, Indian chapter 2021 to 25. He is fellow of American College of Endocrinology, American College of Physicians, and a fellow of all four Royal Colleges of Physicians, that is London, Edinburgh, Glasgow, and Ireland. He has been overseas regional advisor, Royal College of Physicians of Edinburgh, for North and Central India from 2019 to 2024. He has been EC member All India for and the RSSDI National from 2019 to 2022. And he's honorary secretary of RSSDI of Delhi chapter. He is founder and secretary general and Innovative Physician Forum IPF. Dr. Sharma is president at IMA KBB New Delhi 2021-22. He is member of International Advisory Board, Journal of RCPE, Associate Editor, Medicine Update 2019, as editor of Monograph on Emergencies in Diabetes and Endocrine Diseases 2019, and Injectable Therapies for Diabetes Management 2020. And Dr. Sharma is recipient of Lifetime Achievement Award 2018 from RSSDI Rajasthan chapter. Welcome, sir. Then Dr. Lieutenant General Ved Chaturvedi. Dr. Ved Chaturvedi is ex-president of Indian Rheumatology Association. He is ex-president of Delhi Rheumatology Association, ex-head of Department of Rheumatology, Research and Referral Hospital, New Delhi. Dr. Chaturvedi is ex-honorary physician president to India, and he is the first rheumatologist in the country to use new therapy for arthritis called biologic since 2000, and to establish MSK ultrasound and medical arthroscopy in 2003. Dr. Chaturvedi has been past editor of Manual of Rheumatology, and he is president awardee. He received PVSM, which is the highest peacetime army award. Welcome, Dr. Chaturvedi, to the board, sir. And next panelist, we have Dr. Sapan Pandya. Dr. Sapan Pandya is a consultant rheumatologist at Vedanta Institute of Medical Sciences, Ahmedabad, and he is secretary of Indian Rheumatology Association. Dr. Pandya is also attached to VS Hospital, Ahmedabad, as honorary rheumatologist and visiting assistant professor in rheumatology. And Dr. Pandya has been training post-MD residents in rheumatology, and Gujarat University has approved 2-year fellowship in musculoskeletal medicine. He has certified in short courses for basic biostatistics and scientific writing conducted jointly by National Institute of Health Bethesda, USA, and SGPGI in years April 2011 and April 2030. Dr. Pandya has organized the Indian Rheumatology Association annual conference in November-December 2012 at Ahmedabad, and he is presently secretary of Indian Rheumatology Association. He has several publications and many papers, presentations to his credit, namely at American College Rheumatology, October 2008, the International Jograns Meeting, Brest, October 2009, and the Asia Pacific League Against Rheumatism, Hong Kong, July 2010, and Indian Rheumatology Association Conference, November 2010. And among basic research also, Dr. Pandya has worked on neutrophil apoptosis in synovial fluid of patients with RA and OA during DM at the SGPGI, and he presented poster on same at IRA. So welcome, Dr. Pandya sir. We have Dr. Indrajit Sarkar with us. He is a senior consultant orthopedic surgeon at Nightingale Hospital, Kolkata. Dr. Sardar is past president of Indian Arthroplasty Association. He is past president of West Bengal Orthopedic Association. He has been organizing secretary of IOACON 2019 and organizing secretary of ISHKS 2030. Dr. Sardar has been president of organizing committee at NailsCon 2010, and he has more than 100 presentations at state, national, and international meetings, and the white paper on IOACON 2008 Bangalore. And Dr. Sardar has been past reader Department of Orthopedics at IPDMER, Kolkata. So welcome again, all of the esteemed experts and panel members for today's meeting. Now, I hand over the session to our international speaker, Dr. Robert, please. Dr. Robert, sir, over to you, please.
Good evening, everybody. It's an honor to talk to you today and to be a member of this esteemed group. A world expert on metabolic syndrome, Dr. Sharma, Dr. Chaturvedi, a pioneer of ultrasound and rheumatology in India. And of course, ultrasound is so important here in the USA in gout assessment. And Drs. Pandya and Sardar, whose expertise in rheumatology and orthopedics are certainly highly relevant to the topic at hand. My heart goes out to the people of India for this terrible coronavirus crisis. And
hello, sorry sir, sorry to interrupt sir, your voice is quite low. May I request you to kindly bring the mic near to you, sir? And
okay, yeah, my heart goes out to the people of India for the coronavirus pandemic issues that are so terrible worldwide and affecting India so badly right now, and my empathy and admiration to the physicians in India for their tremendous work in trying to control the pandemic. It's an honor to be here to talk to you today. I'm going to focus my discussion on precision management of hyperuricemia and gout and what the impact is for India. India, I think, has a very important role to play on the global stage. Also, one of the major sources in the world of colchicine and this plant Colchicum autumnale, growing in the Karnataka region of India, of course. Here are my disclosures. And I think that this audience knows very well what the definition of gout is. And so I won't dwell on it, but basically this is a disease of excess uric acid stores and of hyperuricemia and of crystal deposition of monosodium urate in tissues. And it's a disease that's not limited to acute flares of gouty arthritis. Really, these flares are built on a foundation of chronic illness, and the body's reaction to urate crystal stores and excess urate crystal stores in particular is associated with the formation of tophi, which are microscopic as well as macroscopic under the skin and palpable. And tophaceous gout is really the most severe form of the disease and associated with some very bad outcomes. And then renal disease, clearly beyond urolithiasis, the issue of people with chronic kidney disease having a 10-fold higher prevalence of hyperuricemia, and the association of chronic kidney disease with difficult to manage gout, and the issue of whether our treatments are impacting on the progression of chronic kidney disease to end-stage renal disease.
Sorry, sir. Sorry to interrupt again, sir. The voice is still very low, sir.
I will try to speak more directly into the microphone. Is that better?
Yeah, it's better now, sir. Yes, sir.
Okay, thank you. So we have a major problem with gout and hyperuricemia in the United States. And you can see the numbers, about 4% of adults have the disease, and the global prevalence is exploding. And basically, we're talking now about approximately 41 million cases worldwide, 7.4 million incident cases per year. A lot of this is related to changing economics and the factors including industrialization and people getting more of the comorbidities that are associated with gout and hyperuricemia. And the point prevalence varies a lot, but basically, if we look at India, it's a significant prevalence. It's not just limited to the large middle class in India, and much of the disease is related to genetic predisposition to hyperuricemia, and East Asians and South Asians do not have very good genes when it comes to limiting hyperuricemia. And so you all in practice in India see patients with pretty severe gout. So really a perfect storm defines the increasing global prevalence of gout, and also the type of patients that we see, and the clinical complexity of these patients is now different than it was 2 to 3, 4 decades ago. We're seeing cases in older people with an accumulation of comorbidities, and the fact that we can allow people to survive more with cardiovascular and renal diseases and diabetes means that they survive with hyperuricemia, they get more gout. And then we do a lot to promote gout by promoting the better outcomes and survival of people with comorbidities. This includes the iatrogenic factors, use of diuretics, including loop diuretics, which are so potent in raising serum uric acid, the common use of low-dose aspirin and cardiovascular prophylaxis, and then mega trends in diet and alcohol consumption in prosperous countries and in the less prosperous countries as they get more prosperous. And then the marked increase in comorbidities that promote hyperuricemia, including obesity, metabolic syndrome, diabetes, type 2 diabetes, hypertension, chronic kidney disease, end-stage renal disease, and congestive heart failure. And then we see terrible gout because, in part, we have limited therapies for the most refractory disease. So uric acid is a product of xanthine oxidoreductase, which we commonly call xanthine oxidase. It actually is present in a reduced form, xanthine dehydrogenase, and in an oxidized form. And in the oxidized form, one of the issues is that xanthine oxidase in the oxidized form produces reactive oxygen species with adverse events in terms of the inflammation aspect of human biology. And allopurinol has a purine-like backbone, and allopurinol and its major active metabolite oxypurinol are competitive substrate inhibitors of this enzyme whose structure is indicated here. Whereas Fabixostat is a channel inhibitor, and it's a very selective inhibitor. Allopurinol inhibits purine and pyrimidine metabolism is also affected, pyrimidine metabolism also affected, and allopurinol is reincorporated back into nucleotides, and this is part of the pharmacology of allopurinol that can lead to issues with tolerance, and also the long-lived circulating metabolite oxypurinol is really immunogenic in so many people and can lead to severe hypersensitivity reactions. So important to focus on the basic pharmacology and the differences right away between allopurinol here, this purine-like backbone, and Fabixostat, which does not have a purine-like backbone and is not cross-reactive. It is not cross-reactive with allopurinol. So the factors promoting hyperuricemia and gout, I mean, it's mainly inefficient excretion of uric acid by the kidney, but also by the gut in some patients, and this is the majority of patients with gout. And then diet alcohol is blamed probably for too much of the issues of hyperuricemia and gout, but still plays a major role. The problem is that when you have a patient with gout, they've had years and years and years of uric acid accumulation, and medical management of hyperuricemia is more effective than trying to limit patients' diets to get down the serum uric acid. And then overproduction of uric acid is the dominant cause of hyperuricemia in only a minority of patients with gout. And the X-linked gene mutation disorders that can cause this are rare. So clinically, you know, the issue is that gout has to begin somewhere, and it begins with asymptomatic hyperuricemia, but many of the patients with asymptomatic hyperuricemia develop urate crystal deposits in tissue, especially everybody with a level over 10 milligrams per deciliter, that's 600 micromoles per liter. If you do an ultrasound on their joints, they'll all have urate crystal deposits pretty much. And then over time, you get acute arthritis flares, which generally increase if hyperuricemia is uncontrolled. And the chronic phase is advanced gout with joint damage due to erosive synovitis, very much behaving like pannus and rheumatoid arthritis, and palpable tophi are the biomarker of that. They're seen, they're felt under the skin. So, you know, what's interesting is how some people think that the tophus is just a rock of urate crystals. It isn't. Only about a third of the tophus is comprised of urate crystals. And in the tophus, actually, there's granulomatous pathology with here urate crystals in a central core surrounded by B cells, T cells. What are they doing there? Well, they're doing something, as well as neutrophils, macrophages, fibroblasts, and other cells. And then there's osteoclastogenesis, the tophus bone interface shown here, and then this tremendous fibrosis that it really is interspaced with aggregates of urate crystals and chronic synovitis. So the tophus is a mix of a lot of different types of inflammatory reactions. And so this, I think, is reflected in the pathology of gout that is quite unique. Episodic flares of acute inflammatory arthritis, here very angry looking, red, swelling that's well beyond the joint line, extremely painful, mediated by the NLRP3 inflammasome activated by urate crystal interaction with macrophages, lots of neutrophil influx, and these flares on the basis, flares superimposed on chronic disease of acute arthritis. And then the destructive chronic inflammatory aspects of gout. I'm sure many of you see these types of patients who have terrible tophaceous disease. There's erosions that look like pannus with outside in erosive changes outside the bone, here shown by dual energy CT. And then this is a patient of mine in clinic who presented with chronic polyarthritis, swan neck deformities, ulnar deviation, who had gout, chronic symmetric erosive polyarthritis. So again, the pathology is very complex in gout and includes innate and adaptive immune mechanisms. This type of erosive disease really must involve IL-17 and the IL-23, IL-17 axis, and the experiments published in the literature to date support this. So tophi are not simply erosive. Tophaceous gout is not simply a disease of erosive arthritis. When you look at in the clinic at a patient with tophaceous gout, you're looking at somebody that has increased all-cause mortality, increased cardiovascular related mortality, increased non-cardiovascular related mortality, and in this paper from Science Reports, a GFR decline associated with tophaceous gout, which is an astounding number of approximately 5 mils per minute per year GFR decline with tophaceous gout. So tophaceous gout should ring all the fire alarm bells that you've got somebody that has systemic disease that's going to imperil their kidney survival, that's going to impair their total survival and the cardiovascular survival and mortality. And so basically, we got to diagnose gout to start with. I think this audience is very familiar with the diagnostic features of gout clinically, these angry flares that reach a maximum of pain within a day. And then if you see a palpable tophus or tophi, well, that's crystal proven gout. And then, the gold standard is seeing urate crystals in joint fluids, which are detected by compensated polarized light microscopy, but this is not always practical. And ultrasound has been a big advance in the clinic. I use it every day I'm in the clinic for diagnostics. And dual energy CT is less widely available. It's more sensitive and specific, but it's more expensive as well. And then the uric acid can be normal or only moderately elevated during an acute attack of gout. So the drop in uric acid in the serum can be one of the factors precipitating an acute attack of gout. And then you have to exclude other conditions. So we're all, I think, on the same page in terms of the diagnosis of gout. And then ultrasound, again, very, very useful. Seeing the double contour sign, it's indicative of urate crystals on the surface of the articular cartilage here, whereas with CPPD, calcium pyrophosphate crystal deposition disease, the contour here above the subchondral bone is within the cartilage, and so there's quite a distinction between this double contour sign and that extra contour in the cartilage. So this is really how we use, in the United States, we so widely use ultrasound as a diagnostic. So how do we manage gout? Well, we got to manage the whole patient. And we try to link the long-term management goals, starting with the education of the patient and getting them to adhere to treatment, which is a big problem in the United States. The majority of patients in the first year of therapy actually stop allopurinol at least once in the first year of therapy. And the same with Fabixostat. So they stop their uric acid lowering treatment, and they think they can master the disease, many of the people, by controlling their diet, and they realize that it's not the case. So we want to identify and manage the comorbidities that cause hyperuricemia. We want to diagnose, treat, and prevent acute gout flares, and we want to use uric acid lowering drugs. We want to treat to a target of serum urate that's substantially below the saturation threshold to suck the urate out of the tissue crystal deposits by lowering the serum urate in blood. So this is the standard approach that we take in the USA to treat gout. And we luckily have many options to effectively treat gouty inflammation, including the on-label options, NSAIDs, colchicine, systemic steroids, local injection of steroids into the joint. We don't use ACTH too much in the United States. It became very expensive. And then off-label, we do use anakinra for patients, especially with advanced comorbidities of chronic kidney disease or congestive heart failure or poorly controlled diabetes. We sometimes use off-label IL-1 antagonism for a few days, 3 to 5 days, 100 milligrams a day to treat severe gout flares, generally in hospitalized patients. And then colchicine is very effective, and it's effective in prophylaxis, and it's effective in acute gout, and we only need limited dosing. And colchicine has been around for 2,000 plus years because it's very effective, and it still is effective. We just have to dose it properly. So what are the indications for serum urate lowering therapy? They're broad in gout. People with a frequent acute gout attacks, we call that 2 or more per year, but really one severe attack, especially an attack that a flare that leads the patient to come to the hospital, to be admitted to the hospital, that's enough. If you have visible, palpable tophi, in my case, I mean, you know, I think that radiographically detecting tophi is good enough to be an indication for therapy. A defined condition causing uric acid overproduction, like PRPP synthetase superactivity or HPRT deficiency, is clearly an indication, or myeloproliferative disease like polycythemia rubra vera, or another myeloid malignancy or lymphoid malignancy causing uric acid overproduction. People who have gout and kidney stones should be treated with uric acid lowering drugs. And then anybody who it's very difficult to treat their attacks. I mean, people with stage 3 CKD should all be on uric acid lowering therapy. Patients who get polyarticular gout attacks, patients with major organ transplant or congestive heart failure. The guidelines of the American College of Rheumatology and of EULAR do not recommend a treatment of asymptomatic hyperuricemia because of a lack of evidence basis. And so we don't, in the United States, treat asymptomatic hyperuricemia except in unusual circumstances. I know that in Asia, for example, in Japan, that low dose xanthine oxidase inhibitor treatment is used for asymptomatic hyperuricemia, and some advocate that also in other places in the world, and some in India as well. So if you achieve the serum uric acid target of less than 6 milligrams per deciliter, that will improve your outcomes. It'll reduce the size of tophi. It'll lower the frequency of gout flares. Eventually, it takes a year or two typically to do that, but some people respond more quickly. And then you need to maintain that effect to sustain the benefits. And gout flares, we know, increase early in treat to target uric acid lowering therapy. So we tend to use colchicine gout flare prophylaxis, especially in people with lots of flares, with frequent flares, and particularly severe flares. So diet and alcohol consumption, I mean, clearly a factor in hyperuricemia. The problem is, I mean, also very, very effective in terms of reducing the triggers of gout flare that are dietary, but much less helpful in uric acid lowering in established gout, where over many years there's been a buildup of uric acid stores. A healthy diet has its limits in terms of how much it drops the serum urate in established gout. And the bottom line is, in the average patient that you see in the clinic with a serum urate of at least 480 micromoles per liter, the amount that diet and alcohol limitation, a so-called healthier diet, drops the serum uric acid is not enough to get the serum uric acid to target in the majority of these patients. That said, it's a good health measure to have people on a healthy diet and to have moderate alcohol consumption. But generally, we need to use uric acid lowering drugs in patients with gout who have a serum uric acid of greater than 480 micromoles per liter. And then, you know, there's a hierarchy in the uric acid lowering drug strategies, but the first drug choice is going to be a uricostat, so-called uricostat agent, a xanthine oxidoreductase inhibitor. Allopurinol, Fabixostat are the top choices. There's other xanthine oxidase inhibitors in development around the world. And then the alternative drug choice is the uricosuric agent. That's less popular. Benzbronerone is limited in its availability. It's a potent uricosuric. It's not available in the United States. It never will be, really. It has the unfortunate ability to idiosyncratically cause severe liver damage and to be lethal. And so that's one of the issues. Also, uricosurics can frequently cause kidney stones. And so where I use uricosurics in my practice is if somebody is on a maximal dose of Fabixostat or allopurinol, and their uric acid isn't a target, especially if they have tophaceous disease and many gout attacks, I try to get the uric acid to target by adding a uricosuric onto the Fabixostat or allopurinol. I usually use probenecid In the United States, that's the most popular uricosuric, but only a few patients in the United States, about 1 or 2% of gout patients, are on a uricosuric agent. And then in the United States, we have pegloticase, which costs about $250,000 per year. And it's really for the worst of the worst in gout. We found that you have to add an immune suppressive like methotrexate on top of the pegloticase to effectively get them through the regimen in about 70% of cases, rather than people who are on pegloticase alone fail in about 60% of cases over a few months. The drug loses its uric acid lowering effect because of treatment emergent antibodies to this very highly immunogenic molecule. So this directly degrades uric acid, and the results are spectacular. Tophi can melt away in 6 months when it works, but it's not universally available. And I'm not sure that it's available in India. So the fundamentals of allopurinol are important to talk about because we have the risk of a severe allopurinol hypersensitivity syndrome. And then if you start allopurinol at a higher dose, you get more early gout flares. So the dose is increased steadily to achieve the optimal serum uric acid target, and you have to monitor the patients. The problem is that when you get into chronic kidney disease, allopurinol becomes even more complex, and chronic kidney disease prolongs the half-life of oxypurinol, which is the major circulating active metabolite of allopurinol, as I've mentioned. And the problem is that oxypurinol is primarily eliminated by renal excretion. And so the allopurinol starting dose and the maximum maintenance doses are reduced in severe chronic kidney disease, starting with stage 3 chronic kidney disease, so-called moderate chronic kidney disease. Allopurinol, in about 2 to 5% can cause toxicities, including the ones listed here. Often the abnormal liver function test, though, that's the fatty liver disease of the patient. It's not the allopurinol. And the same is the case for Fabixostat. One thing that allopurinol does, again, it's non-selective, is some people have vague central nervous system symptoms with allopurinol, and you really can't tolerate it. Brain fog and other things like that. And then one issue with allopurinol is its immunogenicity. Allopurinol is a drug that somehow settles into the corner of the peptide binding pocket of HLA-B5801, and this deforms and expands this binding pocket, and then endogenous self-antigens can get into the pocket. And then you get a cytokine storm syndrome with broad autoimmune attack on multiple organs. And you can get a very severe systemic illness, immune-mediated, with a mix of fever, eosinophilia, toxic epidermal necrolysis shown here, Stevens-Johnson syndrome shown here. These two very often go together. Vasculitis, renal failure, liver damage, progressive liver disease, and a mortality rate of 25%, which we're not able to improve. It's just not something we found an answer for in terms of this very severe hypersensitivity syndrome. And, in the United States, it's not as common as it is in South and East Asia. It's more common in stage 3 chronic kidney disease. The risk of allopurinol hypersensitivity syndrome is much higher in most South and East Asian countries, also in Africa and African Americans. This is mainly because the HLA-B5801 class 1 histocompatibility antigen, this prevalence is much higher than the 1% it is in the United States. For example, in South and East Asians, it's somewhere between 8 and 20% are HLA-B5801 positive. And if you are HLA-B5801 positive, the hazard ratio of getting severe allopurinol hypersensitivity syndrome varies between 100 to 600 to 1. Actually, in one Chinese study, it was exactly 580 to 1, which is sort of remarkable when you think about it. That's a coincidence. So nearly all allopurinol hypersensitivity syndrome develops within the first year of giving allopurinol, mostly in the first 2 to 4 months after starting the drug. And it's a horrible thing to see. And we here have seen patients who've died of allopurinol hypersensitivity syndrome. And so it's a huge issue. And I think the Indian physicians are pretty aware that for HLA-B5801, this is the hot zone for HLA-B5801. Japan is not in the hot zone. It's only about 1% HLA-B5801, but India clearly is. Again, about 8% here for HLA-B5801. And the Han Chinese, Koreans, Vietnamese, Pacific Islanders, Koreans. I mean, this is really North Asia when you talk about Korea. This is the hottest zone in the world for HLA-B5801. So this is part of precision medicine, really, in gout management. So the fundamentals of Fabixostat, well, again, it's not cross-reactive with allopurinol. Okay, does not have that purine backbone. More selective inhibitor of xanthine oxidase than allopurinol. Again, important pharmacology. It's primarily metabolized by hepatic oxidation. Therefore, dose reduction is not needed in moderate renal or liver impairment. Not needed in moderate or renal or liver impairment. It's very useful in moderate to severe chronic kidney disease. The most common side effects: rash up to 2%, elevated liver function tests up to 5%. But again, so often those LFT elevations of transaminases are due to fatty liver disease, which is so commonly associated with gout. And then some people have reported diarrhea and dizziness with Fabixostat. It's a rare side effect. And then uncommon is a drug reaction with eosinophilia with Fabixostat, but it is reported. And then treat to target Fabixostat in early gout by this study by Nicola Dalbeth, looking at the MRI synovitis score, looking at flares, really by months 6 to 12 and by months 16 to 24. There's markedly reduced flares compared to placebo for early gout. And flares is a very important clinical outcome, obviously, but also the MRI synovitis score with Fabixostat so much better than placebo alone. So this treatment of early gout has lots of yield with Fabixostat. And then I think one of the things that people don't think about in everyday clinical practice when you're putting pen to paper and prescribing is, are you doing something good for patients by inhibiting xanthine oxidase to treat their gout and hyperuricemia? And we recognize, as I mentioned, that xanthine oxidase and the oxidized form leads to reactive oxygen species generation here, but when it breaks down hypoxanthine and xanthine to generate uric acid here. And oxidative stress is not a good thing when you're talking about aging or inflammatory disease because of these abilities here to muck up the mitochondrial function, to promote NF-kappa B activation, to activate the NLRP3 inflammasome and promote IL-1 beta release. And xanthine oxidase is a player in atherosclerosis, obesity, and in non-alcoholic steatohepatosis. It affects monocyte macrophage function. Monocytes and macrophages express xanthine oxidase. So do fat cells, and clearly so do hepatocytes, because hepatocytes make most of the uric acid that we generate in our body. So what's really interesting now is the emergence of approaches where people are looking at xanthine oxidase inhibitors as potential to treat glucose intolerance, insulin resistance, and to treat diet-induced NASH, hepatic non-alcoholic hepatosteatosis. And what's interesting in this particular study from Science Reports in 2020 was that the parameters of insulin resistance, of glucose intolerance were improved in this study by Fabixostat, but not significantly by allopurinol. And then at 24 weeks, here's Fabixostat, allopurinol. This is a folate-rich, fat-rich diet. And Fabixostat did much better at 24 weeks in preventing all of, you see this tremendous steatosis, this fat deposition in the liver, and you see this tremendous fibrosis improve more by Fabixostat, but compared to allopurinol, whose effects were not significant in NASH. So this study was very intriguing. And then also a study on experimental atherosclerosis. We realized that atherosclerosis is driven by macrophage activation, but also there's cholesterol crystals in the artery wall. And also there's urate crystals in the artery wall by advanced imaging studies and by other approaches that are more specific even than that. And Fabixostat here in this study from Lausanne, Switzerland, and from Japan, when you look at the aorta here in this en face preparation, Fabixostat decreased atherosclerosis in ApoE knockout mice. And you can see the tremendous drop in the MoMA2 stains from macrophages, a lot fewer macrophages in these lesions. And the oil red O staining is also decreased here. The red oil red O staining is decreased here with Fabixostat compared to vehicle in this model of atherosclerosis. And so how do we line up related to India, allopurinol versus Fabixostat in terms of the prescribing and the indications and the other precision medicine pharmacology issues? Well, first of all, Fabixostat is, again, highly specific and potent as a xanthine oxidase inhibitor. It also inhibits both the reduced and oxidized enzyme forms. Well, allopurinol and oxypurinol fall off the reduced form more readily than Fabixostat does. The dosing titration range here with allopurinol is a little broader than Fabixostat. Here it's 50 to 800 milligrams a day. Fabixostat is 20 to 120 milligrams a day. So broad range, but a little narrower for Fabixostat. A major risk of severe hypersensitivity syndrome with allopurinol. And then, HLA-B5801. In the United States, it costs about $200 to do HLA-B5801 before you give allopurinol. You don't have to do HLA-B5801 with Fabixostat. And then chronic kidney disease, a predisposing factor to severe allopurinol hypersensitivity syndrome, much favorable prescribing of Fabixostat in chronic kidney disease. A high prevalence of allopurinol resistance in India for reasons that I'll go into, related to this genetic variant, single nucleotide polymorphism that encodes Q141K variant of the urate transporter ABCG2. And that means that allopurinol dosing in India, basically you're talking about, a very large fraction of patients will be resistant to allopurinol, will need much more high doses of allopurinol because of the high prevalence in India and in Indian gout patients of this particular single nucleotide polymorphism. This is not an issue in Fabixostat pharmacology. And then dominant hepatic degradation rather than renal elimination, which is an advantage in CKD. This is an advantage of Fabixostat. Ease of use in combination therapy with a uricose uric. Uricose urics can promote oxypurinol elimination. So when I combine a uricose uric with a xanthine oxidase inhibitor, it's generally adding it on to Fabixostat. And then dose limiting in stage 3 CKD for sure with allopurinol. The same with even more with allopurinol. The maximum dose of allopurinol with a GFR of 15 or less is 200 milligrams a day, which is way below what's in 40 milligrams a day of Fabixostat. And this is due to the impaired renal oxypurinol elimination in chronic kidney disease. And then this inhibitory effect on experimental non-alcoholic steatohepatosis and associated issues in insulin resistance and glucose intolerance, Fabixostat working and allopurinol not working. So what is ABCG2? Well, ABCG2 is the new exciting precision medicine issue here in gout, because ABCG2 it's expressed in renal proximal tubule cells, and it excretes uric acid. It excretes soluble urate, where uric acid is eliminated by the kidneys, but also it's expressed in the small intestine. And it promotes the excretion of urate in the small intestine. The dominant effect of ABCG2 is in the small intestine. And the urate that's excreted into the small bowel goes to the colon, where the colonic bacteria, which have uricase, break it down. This is a wonderful and beautiful elimination mechanism for urate that accounts for about 200 milligrams a day in the normal individual of uric acid elimination. And then the maximum is about 300 milligrams per day, but it becomes more important, much more important, in patients who have CKD, this gut mechanism of elimination of urate. And ABCG2 variants is very prevalent here in these Manhattan plots, very prevalent in multiple populations. This is a common gene variant. And it's very strongly linked with the susceptibility to hyperuricemia and gout, and particularly so in East and South Asian populations. This is an East Asian population study. ABCG2 is a top gene variant, and basically this is very common. And if you have defective ABCG2, what happens is we can tell in the clinic. We have a South or East Asian extraction patient that comes in that's 27 years old, that had gout starting at age 21, that has tophaceous disease, severe gout flares. And we don't get a genetics consult. We know that this patient most likely, by far, most likely has the defective ABCG2 gene variant. There's several, but the most common one is the one that encodes Q141K, linked to early onset and tophaceous gout. So when you're in the clinic and you see these type of patients, you know what you're dealing with. And then this variant is the one linked to allopurinol drug resistance. And this variant increases inflammation responses in experiments. And also, what's really interesting about Q141K is it transports indoxyl sulfate, helps to get rid of it. Indoxyl sulfate is hard to get rid of. It's protein bound. It's a uremic toxin. And if you have deficiency of ABCG2 in an animal model of chronic kidney disease, your kidney survival is horrible. So this is really a very prevalent variant, the ABCG2 single nucleotide polymorphism here encoding Q141K, very prevalent in India, East Asia, much of North Asia, and basically you've got an allele frequency of about 10% in whites and 30% in East Asians, which means about half your patients with gout in East Asia will have this variant. Very important consideration when I in America have a Caucasian patient and an East Asian patient. And in India, the allele frequency of ABCG2 is about 15%. So, it's going to be about 25 to 30% of gout patients that have this, but we don't know the exact number because those studies have not been done yet on gout patients. And so you need double precision pharmacogenomics. I'll repeat that. Double precision pharmacogenomics. If you are treating gout patients in India, and you're most likely going to use a xanthine oxidase inhibitor. The first one we mentioned, HLA-B5801, India is in the hot zone, having about 8% prevalence of HLA-B5801. And then Q141K, high allele frequency in the overall Indian population. We suspect, about 30% of Indian gout patients would have ABCG2 Q141K. It encodes allopurinol resistance, and it encodes a risk of early onset tophaceous gout with more inflammation and more uric acid excretion in the kidney because the gut excretion is impaired. We call that renal uric acid overload gout. The last thing you want to give those patients is a uricose uric drug. and there's a more risk, we think, of kidney stones and renal damage. So gout interweaves a lot of elements. The simple elements are dysregulated uric acid balance, urate crystal deposition, inflammation, arthritis. And then there's lots of exposures, and then there's the comorbidities. And so we have a situation where gout is really not simple, because we have an intersection of comorbidities, exposures, xanthine oxidase, hyperuricemia, arthritis. And so is there any way, when we're treating the comorbidities, or when we're treating gout, can we affect the comorbidities with our treatment? And when we're treating the comorbidities, can we affect gout and hyperuricemia with our treatments? Well, losartan is uric acid lowering. It'll lower the uric acid in the serum by about 10%. Not that much, but every little bit helps. And then type 2 diabetes, the big story is the SGLT2 inhibitors. And then there's emerging stories on how treatments that we use for gout patients can help with comorbidities. So what are some of these stories? Well, the deleterious effects of xanthine oxidase and uric acid need to be considered, because uric acid elevation experimentally increases blood pressure in small animals. It increases fat accumulation, which we don't like, and it increases inflammation. And so there's effects on visceral obesity and on lipid metabolism, on inflammation, insulin resistance, and on NASH, as I showed you. And so actually a study that I was the senior author on, intensive urate lowering with combined Fabixostat and Verinurad, which is a very potent new generation uricosuric, it actually reduced albuminuria significantly in patients with type 2 diabetes. It did not have an effect on the GFR, but it lowered the serum urate by about 60 to 70%, and it decreased the urinary albumin to creatinine ratio significantly here in the purple bars. So this is a really exciting avenue of research. And then the FAST trial shows that, in terms of the structure of the FAST trial, this is a post-marketing study, and they compared allopurinol to Fabixostat, and the exclusions are listed here. They titrated the Fabixostat from 80 to 120 milligrams a day. They treated to target with allopurinol Fabixostat. They looked at these cardiovascular outcomes. It was a really well done study, and really not much difference. I mean, this is not a statistically significant difference, but actually the cardiovascular issues were a little bit more and with allopurinol than they were with Fabixostat. It just didn't reach statistical significance. These were considered non-inferior. So Fabixostat and allopurinol in terms of cardiovascular disease in the FAST trial, non-inferiority issues. One issue here is there was no placebo control. So, we didn't know whether Fabixostat or allopurinol, how much cardioprotection there was compared to nothing, right? But compared to each other, they were pretty close. And then colchicine turns out to be a relatively inexpensive cardioprotective agent added to the standard of care of statins and low-dose aspirin. And this is becoming very popular, has been published in the New England Journal of Medicine, the Journal of the American College of Cardiology, and keeps on getting reproduced. That the colchicine limits acute coronary insufficiency in this patient population that has coronary artery disease. And coronary artery disease in the United States is present in 14% of gout patients in the United States. I'm not sure that there's data for that in India yet, but we certainly want to hear and work with people and collaborate with people looking at that. And then I think this is really exciting, is that the SGLT2 inhibitors, they are uricosuric. They change the way that sodium and glucose are handled in the kidney, and that promotes a uricosuric effect. And so there's lots of, there's risks and benefits with the SGLT2 inhibitors, but one of the benefits is renal protection. And this is a very exciting area of the renal protective effects of SGLT2 inhibitors. But what's also emerging is that the risk of getting gout in patients on the SGLT2 inhibitor here in the lower curve here, the risk of gout over time is substantially lower in patients on SGLT2 inhibitors because of this uricose-uric effect that lowers the serum uric acid about 12 to 15% typically. So this is a really exciting area in medicine now. So the conclusions, in summary, gout and hyperuricemia management should not just be considered something easy and without needing a lot of brain activity. It should be, I think, customized everywhere, but this lecture is targeted to my colleagues in India. And I think that, you know, the precision management of gout in India, I mean, in India as well, multiple comorbidities intersect with gout and hyperuricemia. Some gout treatments can limit comorbidities and vice versa. For example, SGLT2 inhibitors. There are systemic aspects of xanthine oxidase, of hyperuricemia, and of gout on mortality and on metabolic diseases, on cardiovascular diseases that merit much wider thinking when you're in the clinic and seeing patients with gout and who are at risk of these comorbid events or who have the comorbidities. And then there's a double precision pharmacogenomics for India. ABCG2 RS2231142 is you know, very prevalent in India. It's a common variant. And HLA-B5801 is prevalent in India. And so allopurinol resistance, therefore, is going to be prevalent in India. And there's a highly elevated risk of severe, potentially fatal allopurinol hypersensitivity syndrome. And you are going to see a lot of patients coming to you in the clinic, I'm sure, with early onset tophaceous gout, presenting in their late 20s, early 30s, lots of inflammatory issues with flares and arthritis, and high renal uric acid levels. And these patients have two alleles for ABCG2 RS2231142. At least two alleles of this, or one allele of this, and some of the more rare variants of ABCG2. Fabixostat and allopurinol not the same. They have distinct structure, distinct mechanisms of action, distinct metabolism. They cannot be combined, and fortunately they're not cross-reactive. And Fabixostat is selective for xanthine oxidase inhibitor, not the case. Selective xanthine oxidase inhibitor, not the case for allopurinol. And then Fabixostat, but not allopurinol, suppresses model NASH in mice, and Fabixostat inhibits model atherosclerosis in mice. It limits synovitis development in early gout in a prospective randomized controlled trial. It has a higher dosing flexibility and safety margin in chronic kidney disease, and comparable cardiovascular safety in the FAST trial comparing Fabixostat and allopurinol. So this really is the point of precision management of gout relevant to India, focused to India. And I wanted to, before the questions and comments of the panelists and the audience, just promote that I'm the founder and president of GCAN, which is the Gout, Hyperuricemia, and Crystal Associated Disease Network, GCAN. The registration membership are free to those interested in gout and hyperuricemia research. We would love to have colleagues from India involved. We're having our 7th annual meeting. It's virtual meeting, all internet, in October of 2021. The membership registration totally free. There's an early career investigator symposium. We generally have 30 abstracts per year from early investigators. And the submission deadline for the abstracts is usually the end of July. And we welcome our Indian colleagues to join GCAN and to participate with us in global gout research. Thank you so much for your attention. I welcome all the comments and questions.
Thank you, Dr. Robert, for a very wonderful presentation, clearing many doubts, but still there are a lot of questions. And we have the galaxy of panels, galaxy of academicians, General Ved Chaturvedi, Dr. Sapan Pandya, and Dr. Indrajit Sardar, along with Dr. Robert. So now I will be putting questions to you all four one by one. And first of all, my question goes to General Ved Chaturvedi. Sir, in a patient where you see that the uric acid levels in the blood, the serum uric acids are on the higher side, at what level of the serum uric acids you look for the tophi, and when do you indicate and advise the ultrasound, and particularly of which part, which joint of the body? This is for the physicians. Sir, unmute yourself, please.
Look, I was in uniform in the armed forces, so we have a lot of gout in army. And surprisingly, earlier we used to say it's a rich man's disease. But what had happened in this country, especially in armed forces, the people who are coming from villages and they get a good salary, and maybe they have a access to alcohol and a high rich diet. So gout is quite in plenty in armed forces. In fact, when I was doing my DM, I had not seen much gout, but I saw so much gout and I had an ultrasound machine. So what we realized, actually, I didn't know about this double contour sign, which professor was showing. But from the beginning, we were doing a lot of ultrasound, even those people who had little high uric acid. So normal uric acid, we take, say, about 6. So more than, say, there are people who are going for, say, somebody has diabetes, somebody has hypertension, suddenly uric acid is 7, 8, 10. So we used to do ultrasound, though there is nothing which has been recommendation is not there that you do the ultrasound, but as a research purpose, you do see the sometime in asymptomatic patients, the uric acid is high. You can see, you can demonstrate, especially in tendoacalis, you can demonstrate at the, which you call it tennis elbow. You keep passing it to your tennis elbow. But if you do the ultrasound, you can see the crystal there sometimes. So basically, if you have a patient diabetes, hypertension, hyperlipidemia, and uric acid is high, and if you have an ultrasound machine, if you have interest for research purposes, though recommendations are not there, you could do demonstrate the crystals at various places. And of course, now we start recognizing double contour signs. Sometimes we see.
Because what we have been seeing is that when the serum uric acid levels may be normal at times, but still the person has the tophi, or it may have the gouty arthritis. So the clinical features of gouty arthritis are there both for the serum uric acid level that may be normal, but that clinical feature is very, very important. My another question to Dr. Sapan Pandya: how frequently we should measure the uric acid levels in a gouty patient?
Thank you, Dr. Sharma. Initially, when you start the treatment, you could be a little more frequent, say every month. But then after you have put these patients on low uric acid lowering drugs, and they've been on that for some time, then once in every 3 months should be enough to monitor the uric acid levels in these patients. But when you start therapy, you might want to do it a little more frequently.
And once we start the therapy for the hyperuricemia, one thing which I wanted to ask to Dr. Indrajit is that, is asymptomatic hyperuricemia be treated or not? Dr. Indrajit Sardar.
Yes, definitely it should be treated, because of the fact that if there is hyperuricemia, there is every possibility at some time or the other, the possibility of an acute flare or a gouty attack may come up, and the patient is not coming at that time. So we will be treating it on a basis as the standard ones, and keep it as such under control as much as possible.
And to what level the uric acid, serum uric acid levels we should maintain, and how long we should treat the patient?
We would try and maintain it at about 6, or try to be near about that. And the maintenance of it goes on, because we do it with a combination of many things. We haven't really talked about the dietary control of it, and which I would like to pose that question to the panel, how important it is. We use a dietary control together with the uric acidic drugs, and together with that, we are able to get the control right. And then it goes on. I would presume, what general experience I've had in this, and your experience would be much more, but I would continue this in most patients for about 5 years, because it goes on, and we will take that thing, as Dr. Pandya has said, 6 monthly uric acid testing, and judge by that.
And as we all know that since the time the Fabixostat has been in the market and we are using it, the role of allopurinol has practically, I don't think we are using at the present time allopurinol. So is there any specific indication, Dr. Robert, where we should use allopurinol and not Fabixostat?
If you're in the United States, you know, where, well, the United States is a different market. So basically the difference in price between allopurinol and Fabixostat is, you know, somewhere about 10 times the, Fabrystat 10 times the price of allopurinol here. So that's a big issue over here. I don't believe that that's anywhere close to that in terms of the price differential in India.
So with, I think the opinion of the house is that since the time Fabixostat has come, we all are using Fabixostat. So what should be the dose to start with? Like allopurinol, you told that we have to gradually increase. In case of Fabixostat, what should be the initial dose and at what level we should increase the dose? Dr. V. Chaturvedi.
Yeah, normally most of the recommendations always say, I think I'll remove this. I think I feel very uncomfortable. Then I like put it this. So naturally, most of the recommendation, not only for this, for any other, you start with the low dose, whether you want to start allopurinol, you want to Fabixostat. So since he talked about those genes, so we are scared of allopurinol. In fact, believe me, when I was not rheumatologist, I saw one patient of allopurinol toxicity, and we lost. But that lady, I still remember. I was just a new physician, and that time I learned that people can die of allopurinol. So I didn't know about this. Over a period of time, everything developed, and my interest about the gout developed because one of my very close relative, he used to have a recurrent attack, a young child, and I never realized that how he's having a recurrent attacks of the gout. And then he developed renal failure, and then the kidney transplantation. So it's a very close relative of mine. So my interest about gout developed. So we normally uses 40 milligram, and then if it is not controlled, as Sapan was telling, you keep doing it both clinically. So there are two arms. If somebody is taking 40 and his flares are controlled, even if uric acid is high, forget about it. Just maintain with 40. So the clinical scenario is more important. If he says the 40 milligram, I'm okay, then I don't increase. Even if it is 7 or 8, I have not achieved the target. But generally people say you start with 40 and try to achieve somewhere about 6 if you can do that.
Right. Thank you, sir. So to Dr. Robert, I think the clinical symptoms and the pharmacologic and the biochemical assessment in case of uric acid looks as if it is only the tip of the iceberg. And much underlying pathology shows that there are other associated conditions where uric acid is really important. And one important, as you have told, is the NASH. That is the non-alcoholic steatohepatitis. So if we talk today, there is no specific treatment for NASH. Can we use Fabixostat in conditions where the uric acid is normal, but the person is suffering from diabetes, suffering from metabolic syndrome, suffering from NASH and cardiovascular disease? Dr. Robert.
Well, I mean, we have to go with evidence-based medicine. And so, you know, NASH is a huge problem in the United States. And NASH is a big problem in South and East Asia. And many of my South and East Asian patients in the United States have NASH. In fact, in my clinic, I almost routinely, unless the patient has congestive heart failure as a cause of their hyperuricemia or some other very well understood etiology that's not likely to be associated with NASH, I send just about everybody who has not had a right upper quadrant ultrasound for one, and about 70–80% of the time they have fatty liver disease. It's unbelievably common association. The problem is that in human beings, there hasn't been a clinical trial of just a prospective clinical trial of people on Fabrystat for NASH. And, there's reasons to believe that allopurinol may not work for NASH. So the problem is Fabixostat is generic now in the United States. And with clinical trials, you generally need a champion. I mean, there are investigator-initiated clinical trials, but generally there needs to be a champion because clinical trials are very expensive. And NASH clinical trials are extremely expensive because there's got to be an imaging component there. And they're long trials. It takes a long time to get an improvement, right? The biomarker assessment is very complicated in NASH. So there has not been a clinical trial of Fabixostat in NASH. That doesn't mean it wouldn't work, but there's not an evidence basis to say that. And I'm not sure there will be a clinical trial that's at least sponsored by a pharmaceutical company in the United States for NASH. But I mean, it'd be really interesting with my Indian colleagues if there was a clinical trial, prospective clinical trial of just NASH or gout and NASH with Fabixostat compared to another modality. So gout and NASH, well, you're going to give Fabixostat anyway, most likely. But in NASH alone, it would be very interesting, I think, if my Indian colleagues, and I'd be very happy to collaborate, would design a clinical trial to look at Fabixostat in NASH. Ajanta could be a champion, I guess, for that, because it's very possible that this this relatively well-established drug that's widely available and many years of experience with this drug in the clinic, we understand how to prescribe it and use it, could actually have a benefit.
Yes, thank you. Now, there is a very important comment from Dr. Padmasri Gulati from Jhansi. Various epidemiological studies reveal that gout flares are direct result of sleep apnea, and overcoming sleep apnea can cure the gout. What is your take on in this, Dr. Sapan? Gout and sleep apnea.
There are studies where people have shown that sleep apnea is associated with increased gouty attacks. But I'm sure that it doesn't cure hyperuricemia gout because the metabolism is different and the problem is different. But there are associations. I would like to comment on the earlier thing that, while Fabixostat is a drug which is easily available, most guidelines rheumatologists still recommend allopurinol as the first drug of choice rather than Fabixostat, and that is something that we rheumatologists would use. The only condition where we use Fabixostat is when there is a kidney problem, yes. When there is staphylococcus gout, where there is evidence that Fabixostat is better. And now that Dr. Roberts says something which I'm very curious about in NASH, and we have a lot of metabolic problems in India. So as he says, it would really be worth studying in. And so now in patients who have metabolic problems, maybe we should at least have an ongoing study where you compare the two, or just in NASH. But as far as most guidelines go, I think allopurinol is still the first drug of choice. In fact, they recommend increasing the dose to the maximum, which most of our patients actually are not able to tolerate that, and we don't do that. But so that's something that I just wanted to share. But
before Dr. Robert speak, same thing actually I had in mind. Why? And they had not discussed those recommendations, and they came from US only. They have not discussed about the double precision genomic issues. Nothing was discussed. Everything probably more traditional, that if you are using allopurinol, keep using allopurinol. When you showed that map, and not one gene, we knew about 5801, but frankly speaking, I didn't know much about Q1412. So I'm surprised that has not been taken to. So probably right hand does not do the left hand. It looks like. So, Professor Robert.
I mean, guidelines are like an election. And in America, we have a lot of problems with elections, right? I mean, we have still problems with the election after the last one. guidelines are like an election. I know because I did the 2012 guidelines. I was a senior author, and I sat there while people were voting. The task force panel votes, and it's a vote. And like if there's enough votes, then they say, okay, do this. But like precision pharmacogenomics, the guidelines are based on evidence, and you still need more clinical trials. But like the other problem in the United States that we have is that there's a lot of inequality and inattention to the differences between people. What is their racial status? What is their ethnic status? What is their socioeconomic status? And so the guidelines, it's sort of like when you buy a computer or you buy a car, the minute you take it out of the store or out of the car dealership, it decreases in value. So the guidelines, yeah, they're written for the United States. And also the minute they're out there published, they've already depreciated in value tremendously. And I gave a talk today that was very focused on India and very advanced because this is what's going on. I look at the world in a different way, and I look at, I was asked to provide a talk that was relevant to practice in India. And so this is how I see the world. If the American College of Rheumatology had said, okay, let's give guidance on how to manage gout in India, then that would have been different. But like, basically, I think that the people on the panel and the audience, maybe they should publish guidelines. Maybe they should get together and have a vote and publish guidelines on how to manage gout in India based on all of this evidence.
Thank you, Dr. Robert.
I'll tell you, most of the orthopedicians actually uses Fabixostat, because somehow most of the orthopedicians, they are using Fabixostat. But since the guidelines of this thing is there, so it is always there in my mind, the guidelines says Allopurinol. So for the first time now, I'm very clear about this double precision pharmacogenomics. So it is a real danger, actually speaking.
Well, I think that if my colleagues here on this Zoom conference, if you think about this, if you get together as a group and you publish guidelines on how to manage gout in India, then people in the United States may pay attention if they have a patient who's of Indian extraction that comes to them. Because actually I've seen cases, this is tragic. I've seen cases where an Indian doctor has prescribed allopurinol to an Indian patient, and there's been a very bad outcome in America. Okay, so I think that you have to raise consciousness that we're dealing in an era where it's very cheap to do an HLA-B581 in America. $200 in America is considered cheap, and then it's much less expensive every year to do genomics and to think about ABCG2 genomics. But I mean, on a population level, if
Thank you. I'll come to Dr. Indrajit, but before that, I want to go to Dr. Sapan. Dr. Sapan, you wanted to make some comment.
Yeah, the other problem we've seen here, I'm sure all of you would have seen, and especially Dr. Ved, is Fabixostat is a very potent uric acid lowering drug. And one of the markers of potency or competence is the flares. So what happens with the use of Fabixostat if you don't give colchicine is they have severe flares. And I have seen patients coming on stretcher, gouty patients with severe pain flares. Invariably, they have been on Fabixostat without colchicine. So that's another problem, because uric acid goes down immediately to levels of 2 or 3, and they get severe flares. So the other thing that we need to educate, especially the orthopedic community, as Ved sir said, and they use a lot of Fabixostat, is to combine it with something which takes care of the inflammation, because otherwise they are in severe pain.
It looks that the uric acid from the serum goes down, but that crystals in the joint space, they are creating the problem in this situation. Dr. Indrajit, you being the orthopedic surgeon, what is your view about this?
I'm very clear about this, sir, that I use Fabixostat. The reason is very simple. I don't think I'm competent enough to treat allopurinol flares, allopurinol problems. And that is something which requires very specialized treatment in recognition and treatment. So for my case, and I know a number of my colleagues who will use this because of the generalized safety profile of the Fabixostat.
Right. Thank you. So the Indian Rheumatology Association and the Orthopedic Associations of India, they are very robust bodies, and I think in the times to come, they will be coming out with the new guidelines in perspective to India. Now, are these genomic studies, the tests are available in India, Dr. V. Chaturvedi, sir?
I really don't know. Actually, I had never. I knew about 5801. Sometimes we do send it to Lal, and report comes. I don't know whether they are doing here or they are asking from other country, but they do get. I really don't know. Sapan, can you answer?
Yes, the 5801 is, as sir said, some labs do it, but I'm not aware of the other genomics that maybe that is still not being done. It's a part of research.
Because I got 5801 for my, he was my brother's son, so we got it done for them because he was going for renal transplant and acute flares and all these things. So that I don't know whether it was done here or it was done.
Now,
Just a note, can I say something?
yes.
In my hospital, if I have a patient that's of East or South Asian extraction, other than Japanese descent, we won't even give allopurinol unless we get a negative HLA-B 5801. That's our hospital policy, and that's because we've had fatalities, allopurinol hypersensitivity syndrome fatalities, and we're charged with trying to limit death. So, iatrogenic death. So in my practice, I don't even give allopurinol unless I have a negative HLA-B 5801 if I see somebody in a high risk group, African Americans, South Asians, East Asians, other than Japanese descent.
So the reason must have been that the insurance, the cost of the drug, that must be a very important reason in your country. Now,
Oh yeah.
Now, any specific drug interaction we should look for when we prescribe Fabixostat in these patients? Drug interaction.
Well, I mean, azathioprine, 6-mercaptopurine is a huge issue. Allopurinol also interacts with amoxicillin and ampicillin. About 30% of people will get a rash with that, so that's another issue. Theophylline is the other one of the other drugs that we're concerned about, but our major concern is azathioprine and 6-mercaptopurine.
There is a very strange situation that in diabetic patients and in hypertensive, when there is an evidence of coronary artery disease or atherosclerotic vascular disease, we do prescribe aspirin in low doses of 75 milligram per day, and that goes for a very long time. And on the other side, you said aspirin also causes this problem. So how to go about that? Should we add Fabixostat in the patients who are on aspirin regularly or not? Dr. Sapan. Okay, Dr. Robert, you please take this question.
Oh yeah, I mean, look, aspirin does raise the serum urate a little bit, but it's so valuable as cardiovascular prophylaxis. And then in the studies to date, it's very important to think about two things when you prescribe in patients with gout and coronary artery disease. The first thing is do not use NSAIDs to treat the gout flares, because NSAIDs will raise the risk of myocardial infarction. The second is don't stop the prophylactic aspirin, and then you're going to have better cardiovascular outcomes. That's the evidence to date.
In Indian context, Dr. Sapan, what are the foods which we should look for when we talk of hyperuricemia to be avoided?
Yes, Dr. Robert pointed out there are two things. One is there are genetics to diet and hyperuricemia. So only some people with those kind of genes respond to diet restriction. The other thing is that how much ever you restrict the diet, it's going to make a difference of only about 1 milligram percent, not more than that. But if you do want to, then anything that reduces the insulin resistance in terms of high calorie food, in the Indian food, you hardly have anything. I mean, vegetable proteins like pulses and all really don't make that much of a difference, but it is mainly fructose and sucrose. So things like canned fruit juices and, beverages that are available like Coca-Cola and Fanta and those kind of things, or fruit juices. I think those are the main things. You avoid sucrose and fructose and simple carbohydrates more than complex carbohydrates. But apart from that, as far as non-vegetarian food is concerned, yes, maybe seafood and as sir pointed out, red meat and those kind of things are things which you would want to avoid. But it really doesn't make much of a difference in patients who have very high uric acid levels, and you would eventually have to treat them. But yes, anything that reduces insulin resistance in terms of and reducing the weight would probably help.
Apple juice and orange juice, mango juice. I mean, these are all also issues. I mean, basically, it's like having an intravenous infusion of fructose if you have somebody on an empty stomach and they're drinking a lot of Coca-Cola or Fanta or orange juice. And orange juice, apple juice. These are issues. So you're exactly right. But basically, we don't want to lose our patients. We want to keep our patients and keep them healthy. So the problem is you have to tell them that everything in moderation is what we tell them. If you don't restrict their diet to low purine diets, because those are not very palatable diets. I love Indian food. I can't imagine I would love Indian food as much if it's a low purine food.
So thank you, Dr. Indrajit. Any specific other joint you must have seen in acute gouty arthritis? These joints which have been shown by Dr. Robert, we usually see when the patient presents with acute gout. Even on telephone, we can say that, yes, this is your gouty attack. So are there any large joints which are also affected with gout?
Yes, absolutely. The elbow joint. The elbow joint is a big area in which these, not only the gouty tophi comes, but as was said, even in the cases which are going on and on about a lateral epicondylitis or tennis elbow, even then that gouty things comes in. We've seen it in the fingers also. Toes, of course, is there. And the other thing is about knee. One of the problems we have faced is differentiating between an acute septic arthritis and an acute gouty arthritis. And that really comes, there are other factors involved, the other accessory factors like blood counts and toxicity generally and all that, and the clinical features. But it causes a problem. So, and especially the problem that we have seen is after joint replacements.
I just want to add, I was a new rheumatologist, so I was very enthusiastic, and that time I was doing a lot of arthroscopy, and also the Professor Robert showed that type of patient. I knew this is not rheumatoid arthritis, but it was a polyarticular. So we did arthroscopy, and we saw that for the first time something shiny, and then the junior doctor who was there, he already knew, sir, this is called as beach ball appearance. It is already described by somebody. So that is
so
the shine actually during arthroscopy, because you are now orthopedic surgeon, you must be doing, if those people who are doing arthroscopy regularly, off and on they can find out those crystals, they shine in the arthroscopic light.
Yes.
So, sir, is there any role of aspiration from this?
Yeah, very important. Yeah, JK, I have a brigadier with me who had a very severe gout. I still meet him in Gangaram Hospital. And he had a very severe gout. I had tried everything. And injectable steroid, this, that. And one day he had a very severe tophi in the knee. So what I did arthroscopy, washed the whole joint. And after he's taking medicines, colchicine, allopurinol, he's taking for the last about many years. He met me, I thought he was on wheelchair. And one day I met him in the market. I realized he must have become disabled. He had such a severe gout. And he says, no, that knee is perfectly all right.
So the crystal load has significantly gone down.
Maybe, I don't know. I thought I'll share with somebody.
Now, another important is that in today's time, when we are all are looking after the COVID patients. So may I ask Dr. Robert, what is the role of colchicine in COVID-19 patients?
Well, first of all, that we see patients in the hospital who have high inflammatory states with COVID-19, and the patients who have a lot of comorbidities, the gout patients that have a lot of comorbidities, if they get COVID, they can get really sick. And also the non-Caucasian patients in America have more severe COVID. And we've seen people with flares of gout, with pseudo gout due to CPPD, who are very sick with COVID in the hospital. and we treat them. And so that's one thing. Everybody's really interested in medical treatments for COVID that are inexpensive and widely available, and repurposing drugs. And there's been some data from a study from Quebec and from NYU. I was asked to be in the next phase of the study. I just said no, but I mean, there's some data that's been disseminated by a press release. It's still being looked at, but there's some data that argue that perhaps colchicine can have some effect that's positive in limiting inflammation in COVID and progression of the disease. And there's some other data besides that that's published, that retrospective analyses and so forth, some very early prospective studies that argue maybe that colchicine has some anti-inflammatory effect that could limit the progression of COVID. But we really don't have the answer yet, but it would be a beautiful and wonderful thing, actually, if colchicine was effective medically for COVID, but we just don't know yet. And it's very dangerous to speculate because, for example, early on, people thought that hydroxychloroquine would be very beneficial. There was some promising data. And then it turned out that actually the patients on a hydroxychloroquine did worse because of the so frequent cardiac issues with COVID and the potential of hydroxychloroquine to affect the heart. So we have to be very cautious in terms of thinking about unproven medicine rather than evidence-based medicine at this point. But I think it would be wonderful in the end if we had evidence that something like colchicine was beneficial.
Dr. Indrajit, you wanted to comment?
In the COVID patients, there's been a recent paper which shows that the COVID patients, the seriousness of the COVID patients is related to hypouricemia. And the children and they are the ones who may have hyperuricemia. So, and the relationship to post-COVID arthropathy. A lot of these COVID patients, as in chikungunya, come back with this pain in the joints, which goes on and on. Whether it is linked to the uric acid, hyper, whatever, and how effective would be the treatment in that.
Right.
Yeah, I don't know how to interpret. I don't know how to interpret that. People who have, who get really sick in the intensive care unit with pulmonary issues on ventilators and everything. Usually, their uric acid goes up because of hypoxia. So it may be an association bias or something like that. I'd have a hard time interpreting that right now.
So one thing more I wanted to ask Dr. Sapan, is there any relationship between hyperuricemia and hypothyroidism? Have you seen any increased number of hyperuricemic patients in thyroid patients? Any association?
I'm not aware of any. There might be, in the sense that both of them could have metabolic issues, but I'm not aware of any association. I don't really look at hypothyroid patients, so I'm not sure. Maybe somebody else who deals with hypothyroid can answer better. But it makes sense that both of them can have metabolic issues, because hypothyroid patients are known to have cholesterol and hyperlipidemia. So along with that, they might be having a bit of hyperuricemia, but no real causal association, I think.
Thank you. So we have covered most of the questions, but one question to Dr. Robert. So can we consider hyperuricemia as an independent risk factor for diabetes and cardiovascular diseases?
Yes, I think that the evidence is that hyperuricemia is an independent risk factor, but unfortunately, we just don't have evidence from enough prospective randomized controlled clinical trials to, in the United States, we can't provide an evidence basis to add uric acid lowering therapy for everybody with asymptomatic hyperuricemia. That said, it's something that is done in Japan. People with asymptomatic hyperuricemia, for example, they can be treated with 10 or 20 milligrams of Fabixostat a day in Japan. And I'm always interested to talk to my Japanese colleagues as to why. And they don't have an evidence. They can't give me the evidence, but like it's sort of, the problem is when you extrapolate from epidemiology to the medicine practice and prescribing, there's a lot of gray areas there. So in the United States, we just can't do it. And since allopurinol is the most frequently prescribed uric acid lowering drug in the United States, giving allopurinol to a lot of people in the United States is possibly going to cause a lot of problems. Because the 21% of the population in the United States has asymptomatic hyperuricemia. That's a lot of people. 60 million people, yeah.
So we can say that there is lot of scope for the research activities for the genomic studies in India, as you have given us the various evidences also. And I request all panelists from the rheumatology and from the orthopedics to please make a white paper or make the guidelines for we Indian people, we Indian patients, and lot of research. And I request Dr. Kamal, being from the Ajanta Pharma, to plan such studies in association with all the these rheumatology associations, orthopedic associations, so that the research can be taken further, because whatever we see at the present time is only tip of the iceberg, as I mentioned earlier also. So the problem is lot more. So I think I must thank everyone for taking part. Wonderful lecture by Dr. Robert, a good panel discussion by all the panelists, and I'm extremely thankful to everybody, extremely thankful to Dr. Kamal. And now I hand over the proceedings to Dr. Kamal.
Thank you, sir. Thanks a lot. And I wish to extend my heartiest thankful to all of the experts for a wonderful deliberation and wonderful panel discussion followed by that. Personally, definitely, I have gained a lot of new informations in the field of hyperuricemia and gout management, and I'm sure more than 2,000 delegates who have been participating this wonderful meeting would have benefited with this. So with this, sir, again, I would like to extend my sincere thanks to all of the experts, Dr. Robert, sir, Dr. J.K. Sharma, Dr. Chaturvedi, Dr. Sapan, Pandya, and Dr. Indrajit, Sardar. Thank you. Thanks, sir. Thanks a lot for this wonderful program, sir.
Thank you. Thank you, Dr. Robert, and thank you all, everybody.